Yeah, so people can sort of be able to use it. Okay, I'll just continue to share now. So yeah, we have quite a good number of people joining from different parts of the world. UK, someone from Afghanistan, Ghana, India. So thank you, welcome once again. Um, and the other question: have you attempted the IMT interview before? If you can just answer, you can scan the QR code. You should be able to answer. Yes. Okay. Just waiting on more people to join to reply. Oh, okay. Attempted before point table. Good. Well done. Last time. Okay. So we have yes, yes, yes. Okay. Okay. All technical issues. Okay. So yeah, I think we have a mixed number of yes and no. I think more people are still typing. Let's see the comment section. No, no. So we have yes, no. Yeah. So I think we have a good number of people. Okay. I'll just make it. Okay. So we'll move on. We just had Dr. Shion joined us. She's also one of the co-founders and facilitators at the ACE Academy. Welcome. Thanks for joining us.
Thank you very much. Well done.
So by now, I'm sure everyone is familiar with the IMT interview structure and answer, how to, be structured. But if you're not familiar, this is just an overview of what it entails. You're going to have, station one and station two. Your station one will cover questions relating to application and suitability, also ethical professionalism and governance question, and then they'll score you for communication based on your answers. And of course, question station two, the clinical scenario and handover, and you're also scored for communication as well. So, communication cut across, and you're going to have two interviewers in each of the station, each person asking you different questions, but they will both be scoring you. So that's just, if you're not familiar, that's what it entails. And this is the scoring structure. You want to aim for 5 for excellence. And we have Dr. Zika here, Dr. Chiemele, who had full scores in their interview. So, they'll be sharing top tips on how you can do that and resources you can use, because the competition is obviously very, very stiff now. So you want to aim for 5 full marks, excellence. And that is why we are here today. So now we'll be going into the first session by Dr. Zika. So I'll let Dr. Zika take over now.
Hello, everybody. Good evening. Thank you, Leah. Thank you, ACE Academy, for this very helpful. I say very helpful because it was very helpful to me when I was doing mine as well. So without wasting much time, I will be talking about personal preparations, strategies, and how to structure answers to get, like Leah said, the aim is to get 5. The time where 4 was okay is past. People are getting full marks and still ranking 3 digits. That's because of the extent of competition. And with all the changes they already made this year, from shortlisting, the scores were very, very high compared to what used to be before. So that is a reflection of how steep things have gotten. So the aim is 5. Now, Personal preparation, I'd say this is not our first time. We have been doing this for a long time. So we know what works for us. We know what is effective for us. So whatever pattern of studying that you have personally, one thing I would emphasize on is ensure you have daily practice in whatever shape or form, hours, minutes, whatever it is. But from now to whenever your interview date is, make sure you do something every day. Having a practice partner is most helpful. If you don't, when I was on my own, if my partner is not ready, I used to record myself and then listen it back. Because there are certain things you do while you're talking and you don't realize, but when you listen back, you'll be able to say, oh, I waffled a bit here, or I ummed and ahmed too much here. So don't say because if you're practicing with somebody who is at work, that should not be a reason for you not to do something that day. You can record yourself, you can stand in front of a mirror. Just get used to practicing. I will always say at this point, I want to say confidently that the medicine is not the problem. The issue now is how to present the knowledge that we've already gathered. So we are not learning stuff at this point, but everybody coming to that interview knows the stuff. Let's get that out of the way. So we are not looking to see how wonderfully you managed COPD or treated that PE patient, but it's the nuances that makes patient candidate A different from candidate B in terms of how they presented and structured what they are doing. The foundation is the same. So that's where practice comes in. Because there are certain things that if you're doing, like if you're actively doing it in person, you might remember. But somebody should put you on the spot for you to talk about it, you might forget. This is not the time to do that, because even if you know it's like you're functioning at a registrar level, but you miss something vital at that interview is not up to 45 minutes. That is going to determine how you rank. That's a full opportunity that you don't want to miss, because they're not going to come back and realize that, oh, you forgot. I'm not saying we can't forget, but when you practice it so much that it becomes a part of you, like knee-jerk reflex, you're just reeling out the facts, that would greatly minimize the opportunity for you to forget. So for personal preparation, whatever works for you, I'm not going to, like, people know how they study and how things stay, but what I will add is make sure you're doing something every day. Make sure you're getting feedback. That's where you have to practice with somebody. Yes, you can do the personal recording and in front of a mirror, but you also need another ear to hear what you're saying. Because there are things that you might think, oh, this is perfect. And then you say it to somebody and they're like, oh, what if you said this? Or you added that? These are the things that will give you extra marks. Because at this point, the person who knows the answer perfectly is going to score a 3. That's that, like, you are safe, you can manage this patient, we trust that you're a safe doctor. That's a 3. But we are looking for a 5. So you're looking for that additional thing that will separate you from the 3s. And that's where these other things come. And you need to practice to get into the habit of saying it off the cuff. And then when it comes to structuring, so my strategy will be practice, practice, practice. It might sound redundant, but I can assure you you will feel a lot better, because this is December. The maximum date for interviews, I want to believe, is end of February, maybe early March. So we're talking less than 3 months. If you put in the effort, trust me, the coming 3 years will be so worth it. So study whichever way that makes you comfortable, but practice, practice, practice. And then when it comes to structuring your answer, the first thing I'd say is always make sure you know where you are. What I mean is, we are all used to the A to E. They give you anything, you do A to E. That's wonderful. But when you're in ambulatory setting and the patient is not acutely unwell, A to E will not favor you there. So know where you are, because where you are will determine what pattern of answer you'd apply to each question. So if you're in ambulatory care and the patient is fine, because patients can still deteriorate in ambulatory care. So it's not just if they say patient in ambulatory care, that means you take a different approach. Somebody can be in ambulatory care and start requiring 15 liters of oxygen, but where you are and then the situation of the patient. Of course, unwell patients, we all know ATE. You're not sitting there to find out their last menstrual period or any of those history that can be done later. But if you're in ambulatory care, like GP referral, typical SDEC presentation, then you can take time to do a little bit of focused history and then examination and do your investigation, treat, follow up, all of that. One thing I have to say is everybody knows how to do the ATE, everybody knows how to do their examination, whatever findings that they have, get their differentials, investigate to rule in or rule out, all that. But there are certain extras that make you stand out. Things like treatment complications, discussing treatment complication if it applies. Of course, it won't apply in everything. But for instance, if you're seeing a patient that for some reason you have to give antiplatelets, remembering that you need to add a PPI to that antiplatelet, I'm talking of aspirin, clopidogrel, all of that, is the thing that will make you stand out. If it is PE, remembering that, of course, I want to believe that in your history you would have been able to figure out triggered or not triggered, spontaneous or provoked. Because first of all, that would determine the duration of your anticoagulation, but most importantly, follow up in PE clinic. And then counseling on being on anticoagulation. So these are small things that will make you stand out. So say for instance, something like PE, you know that, okay, you're going to look for risk factors or triggers, you're going to put the patient on anticoagulants, right? But going the extra mile is making sure that you do that counseling, booking that extra PE, that follow-up PE clinic. And if this patient is a female, while you were taking your history, making sure to figure out, to take the history about menstrual period, because that will determine whether you're giving them contrast or not. These little things are what will make you get those extra marks and not just, oh, PE, we picked it up, we treated it, patient goes. So, and then follow up. Again, it's not every case that will need a follow up, but most of the cases should have some element of follow up. Then, because the bulk of your patients are going to be in the elderly population, one important thing that you need to always remember is discussing resuscitation status. That's another thing that will give you an extra edge. Figuring out, does this patient need for us to put in a DNA CPR? We need to have that conversation and updating family. Now, all these things in the like the patient who is acutely deteriorating, you can stabilize the patient, but knowing that these other things needs to happen, because if a patient has deteriorated once, there's a high chance that they'll deteriorate again. So having all these things in place would make it easier for the next situation or whatever. So follow-up is something that we don't typically remember. So remember that resuscitation status discussion, updating family, of course, with patient consent, not against the patient's will. So that's how I would say structure your answers for maximum marks. Know where you are and then apply. If you're in ambulatory care and is a sort of stable patient, then you do your focused history, exam, investigations like that. If patient is acutely deteriorating, you go through the usual A to E and manage like that. Then after those extra things, follow up. Is there any complication from the treatment you have given that needs to be discussed or brought to the patient's knowledge? Resuscitation status, family update, of course, with permission from the patient, if they are capacitors. So that's what I would say for structuring your answer. Then the next is the commitment and portfolio excellence. At this point of interview, our portfolio have brought us thus far. It's now how to compress all what we have done into that is 2 minutes, right? 2 minutes presentation that you start with. Because it's in that presentation that you're supposed to demonstrate your commitment to specialty. You're supposed to, again, show how excellent your portfolio is, basically. Now, the CAMPS strategy, mnemonic, is for me is still the best. It's now what you do, like how you express yourself under each heading, and then learn how to present it under 2 minutes, because you can have all the most wonderful things under your camps, and if they cut you off and you don't finish, all that means they didn't hear all of that, and you wouldn't get scores for that. So when I say CAMP, I mean CAMP. So the first is clinical, then academic, management, and then personal. So for your clinical aspect, I'd say condense everything that you have done that makes you an outstanding candidate for IMT. Now, don't do routine things like I know how to take history. No, everybody does that. But there are certain things that is not necessarily expected for, because it is assumed that you're IMT1, so you're like FY2 level. So there are certain things that sort of puts you at a different level from an F2, supposedly. So for instance, if you know certain procedures, say you're competent in doing lumbar punctures, for instance, or cannulating with ultrasound, or what other thing? It mustn't even be
Acidic
stuff
tap,
like that. Acidic tap, thank you.
Anything, yeah.
Yes. That is expected for you to be learning as you start IMT. If you already have those are the kind of things you need to put in your clinical to demonstrate that this is what you want and you've been working hard towards it. And then if you've done any exams, I know that they didn't score you for your exams, but if you've done it, this is where you demonstrate that for you is IMT or nothing. Do you get? Say, even if it's only part one you've done, it doesn't matter. It's not like you have the full paces. No, if you've done part one, put it there. Any clinical thing that you've had, if you had to maybe take a detour, say for instance, you worked in cardiology, and because of maybe say you were struggling with understanding echo, for instance, and then you had to do something extra to help you understand echo. Do you get, like, anything clinical that one would expect that if you don't have it at an FI2, nobody's going to look at you like you're performing under your level. That's where it comes in. Don't say things like venipuncture and blood. Everybody knows how to do that. That's not outstanding. So that's where you put it. Then for academic, again, those things that they removed from the shortlisting scoring, this is where you put it. Have you ever had any? And this goes back to med school. It doesn't have to be something that happened in the last 1 year or whatever. Your any prizes in medical school, if you were the best graduation in anything, any outstanding subject performance. Oh, so I also forgot something. In clinical, if you have ever received any compliment or award for your clinical practice, you put it in clinical as well. So academic, any kind of prizes, any courses you've attended, like, again, if you have, say some people would have done ultrasound courses of some sort, you put it in your academic, because these are things that are expected of you, or you're somehow expected to know it and be doing it on the wards. If you've already done it, that means you've been preparing for this IMT way before time. So you put it there. So courses, awards, competitions. Even if your And what's the other thing? Conferences. Sometimes we underrate conferences. If you've attended any conferences, as long as it's medical, it's not like you did something surgical. No, anything medical conferences that you've attended, you put them under your academic. Then the next is management. Now, sometimes we get caught up with management because we're looking for, like, maybe I was the chief resident in something or something fancy. I mean, if you have fancy stuff, by all means, put it. But it can be as little as you were the group leader in some group project, or you were the secretary of something. Anything that shows that you can manage people in whatever, no matter how small, as long as you're showing that you're going outside of, say, we are all students or we are all choristers, whatever, and you're going outside of the routine role to do something extra on behalf of a group. It's just how you would present it, because as an IMT, you will be managing people. You don't have a choice. People will be coming to you with problems. So you just need to demonstrate that you can handle your responsibility in addition to others and keep things settled and ongoing. And audits, researches, if you have it, come under academic. Sorry, that's what I missed. But of course, I know I'm saying this and it looks like all over the place. You have to arrange it in order. Say for academics, if you want to go from most recent to backward or the other way, if you're going from med school, you put med school things followed by the next thing, followed by the next thing, like that. If you want to come from the most recent, you can do it that way. Now, for audits, particularly audits, well, it's good to say, oh, I audited maybe antimicrobial stewardship or something. It is very important for you to talk about how it's changed practice. Instead of just telling them, oh, I did audit on so and so thing, so it looks like it's a tick box exercise. No, it is more what's led you to do it. So I was on the ward and we're having multiple CD cases, and that concerned me, and I wanted to do something to figure out if there's something that we can do, or if there's something about our practice that is contributing to this, just like something clinical that made you do a certain audit is much more important than reeling out all the audits that you did. Even if you did 74 audits, right? If you can maybe pick out 3 and make a clinical connection to it, it's better than telling them all that you did. And then if you did a research, because if you did a research, I don't know what it would be on. It could be as broad as anything. Just find a way to make it essential to IMT. Say you did something that has nothing to do with internal medicine, for instance. You mentioned that you did the research, but instead of sitting on the idea of the research, you can channel that to, because you know that research is the way to go in medicine, the experience you've gotten in this research, you are going to apply it to medicine related researches. I don't know if you get what I mean, because I know that for research it might be too broad, because I don't know what your background is, but you just find a way to drag it back to medicine. And that 2 minutes presentation with all, and then personal is basically show that you're not a robot. Yes, we know that we all love medicine, we want to be here, but they also don't want somebody who has work and nothing. Show that there is a human side of you. What are you interested in? Dancing, singing, sleeping, reading novel, whatever. Just show that there is a human side, because you need something to unwind. So that comes CAMP, clinical academic management personnel. Just use that for your 2 minutes presentation. And I go back again to practice. During my own time, I pushed myself to practice under 1 minute, 30 seconds. Because by the time the adrenaline of the interview would come, that additional 30 seconds would go. So please practice, practice, practice. Write it down, then practice. Then as a preparation source, you're already doing the right thing by being here. The ACE Academy, they are offering a lot of opportunities. The one-to-one coaching, this webinar, the mock interviews, utilize them, please. There are many body materials. There is the interview book. I've forgotten who wrote it. There's Optimize interview materials. Materials abound, but instead of wanting to use everything, just cone down on one or two and practice. I'm going to put a picture of it on the group. Sorry, I don't remember the name.
Is it the ISC?
Yes, that
so
one. Yes.
we have shared it on the group, and they should have a copy. It's constantly there. They can download it anytime.
Okay, yeah, is that book I'm referring to, that same book. So those are the resources. But if you notice, of everything I said, one thing kept repeating: practice. You can have all these fantastic things about you, and if you're not able to present it in that 30 minutes or 15 minutes, whatever time it is, that will be a whole year lost, because there's no round 2, and we don't want that. Okay, thank you.
Thank you so much, Dr. Zika, for really taking our time to give this session. Welcome once again to everyone who joined while this session was going on. This is the Internal Medicine Training Interview Preparatory Session organized by the ACE Academy. I'm Dr. Leah. I'm one of the co-founders and facilitators. I'm ST6 Acute and General Internal Medicine Training. I also have Dr. Sheon. She's also one of the facilitators and coaches. She's currently ST4 Cardiology Registrar. We also have Dr. Dosu. He's also one of the facilitators and also coaches. He's ST7 Acute and General Internal Medicine Training. Thank you so much for joining us. We also have the panelists. We have Dr. Zika, who is currently IMT2. She had full marks in her interview. That was 2024. Full marks in our IMT interview. Thank you for this session. We have Dr. Chiemele. She had full marks as well, 80/80 in the last IMT interview. She's currently IMT1, and she ranked second nationally. Thank you for joining us. We also have Dr. Balogun, who is currently IMT3, and he's also helped, with coaching and interview a lot of IMT trainees over the years. Thank you so much for joining us. Thank you for Dr. Zika for that session. I remember there's this document you wrote, a very brief document during the last time. So I've shared it on the group. If you're not on the group, I will display the QR code at the end so you can join, because it's a brief guide that Dr. Zika wrote about, how she prepared and the resources, which I think will be useful. We'll move on to the next segment of the session. Just if you have questions, you can either put it in the comment section or keep it to the end, and then we'll cover all of that. So the next session will be by Dr. Chiemele. She'll be talking about, IU strategies, a personal preparation strategy. We want you all to have full marks so that they'll be like, what are we going to do? They'll be struggling like this full mark. So Dr. Chiemele, over to you.
Hi, everyone. Good evening again. My name is Chiemele. I'm an IMT1 doctor in London. I'm very happy and honored to be speaking to you this evening about my personal IMT interview experience. And at the extent of sounding very cliche, I do consider it a privilege, because last year I was very confused, very anxious about this whole process. And it felt like as soon as I clicked my interview dates, it was just an information overhaul, things I had never heard before. But like Dr. Zika said, if you're in this conference, then you're in the right place, because this was one of the first steps I took to really understanding what the process was about. So I'm not going to go over the structure of the interview, because I think Dr. Leah already covered that. Some of the things that I found really helpful for myself are, just like Dr. Zika has said, just practice. I remember hearing that a lot last year as well. And I was like, what are we practicing exactly? But your 2-minute presentation, your suitability questions, every single thing, you need to practice it all the time. I had gotten to, just like Dr. Zika said, write your 2-minute presentation down and then practice it as many times as you can. I did that, and I had done a couple of practices with other people, or like mock sessions with like groups of people, and I realized that lots of people weren't writing their things out. They didn't have it memorized. So I would say write it down and then memorize it. Aim to be able to say it in under 2 minutes, because it's a really, really intense, high pressured environment or a high pressured situation. And it's like that thing when somebody says, tell me about yourself, and your mind completely goes blank. Once they start and they say, give me your 2 minute presentation, you don't really want to be starting to think about all the things you've done. Because if you got all the points to get to the interview, then you've really done great things to be able to, get into IMT interview. So practice your 2 minute presentation every single day, multiple times a day. Make sure you're timing yourself, and make sure other people listening on your presentation as well, so that people can effectively critique you. I think people are, as doctors, so we're very, very good at criticizing things. So let people hear what you have to say. And yeah, so that would be my thing. Write it down, memorize it, and then try to say it under 2 minutes. And even for the suitability questions as well. So you don't know, nobody knows exactly what they're going to ask them that day. Of course, we don't know what they're going to ask us, but there are a couple of questions that they are likely. Oh, there's a way there's something they ask questions around, like, okay, so why should we choose you for IMT, or why are you picking IMT? What have you done to prepare yourself for IMT? Or they'll ask you about the curriculum. If you have access to question banks and things like that, you'll see a couple of these questions. So it shouldn't be, you have things to sort of practice on. And in my experience, so what I did for those questions, because I used Medibody, and that was my study aid, and I kind of wrote my possible answers for, okay, if they ask me this is what I'm going to say. And it was a mix of my personal experience or even personal things about myself. So I had a reason why I was choosing IMT, because there was a particular specialty I had in mind. But these are things that were very personal to me, so it's a bit easier to remember that way. But I would recite these things like multiple times a day. Like I'm going to work, I'm answering the question of why I want IMT. I'm doing dishes and I'm revising those questions, saying it out loud, revising it, so that it kind of sticks in your head. And even if they don't ask you exactly what it is that you've been practicing for, there are lots of questions that you can repurpose the answers for. So I was very sure they were going to ask me, what is the IMT curriculum or something, but I didn't get that question. I got something similar, something I could repurpose the IMT curriculum answer for. So if you don't know the IMT curriculum, then you won't be able to answer, some of the other questions that will follow. So just have your answers, say them over and over again, let people listen on what you're saying, and yeah, practice. And I think Dr. Zika already said having a study partner. I think that was the game changer for me. On the ACE group, someone on the ACE group asked for a study partner for a particular days, because that happened to be my exam days, and I reached out to her. And she was like, from day one, she was on it. Both of us were very accountable to each other. We shared materials amongst each other. We tried to practice almost every day. Obviously, we have on calls. People have other things happening in life, but we really did try to meet at least for 1 hour every day. Try and say, go through the whole interview thing. So start from 2 minutes, do the suitability questions, do the ethical scenarios, and then everything. By the time we were done, I could almost say her own 2 minute presentation, and she could almost say mine, because we had listened and heard it so many times between the both of us. The other thing that I would say that was really helpful, I know someone has mentioned the interview preparation books as well. There was one in particular I read. I don't know if that's the same one on the group, but I think all these interview books are pretty much the same, because they have the same information. I think it's really important to read one of those books, because if you're interviewing from a place, or if you haven't worked in the NHS, for example, there's a way, like it's like NHS speak or NHS lingo. There's some things that people will say just because they've been working in the NHS, so they know how. There's a certain way we say things. So if you have like a clinical scenario where they're saying someone has had like a massive upper GI bleed or something, in whatever hospital you have, there may be a version of major hemorrhage protocol that you can talk about putting out. But if you haven't worked in the NHS, you may not know how we call certain things, or you might not know what a DOLS is, or you might not know what the DVLA is. So these are things that you will pick up from reading these books, visiting question banks, and going the extra mile to learn how we say things, so that you're not losing valuable marks just because you haven't used certain buzzwords. So that would be another tip for me. Let me see. Is there anything I have missed out that I needed to say? Dr. Leah, are you so happy for me to go through the structure for the ethical scenario? Or okay,
yes.
all right,
Yeah.
okay. So yes, so I'll quickly go through the structure for doing ethical scenarios. So the ethical scenarios usually come straight after your 2-minute presentation, and it comes straight after. So I thought they were going to give me like a short break. For me, it just came immediately I finished my suitability question. They said, okay, so I'm going to ask you an ethical scenario now, and then they went off with the question. So I think you have to have been practicing, you have to have been reading all these interview books, you have to have been going through the question banks, because when they ask you a question like that, you have a few seconds, to be able to extrapolate what are the issues that are being reflected in this ethical scenario, because that's how you usually start your answer. So if they tell you, for example, someone has come into hospital with an MI and wants to discharge against medical advice, just listening to the question like that, you have to be able to think on your feet and be like, okay, this is autonomy, this is this, and then start giving your answers. So they don't really give you a break to be able to think and then formulate your answers. So there are different approaches that people take to answering the ethical scenarios. I think the most popular one I have seen is the I Spied approach. And I quite like this one because it's like a checklist in your head. If you can get used to practicing with this structure, it will really help you make sure that you haven't missed out on anything. So the ethical scenarios are either clinical or medical ethical scenarios, or they have to do with like some kind of professionalism. So everything may not be patient facing, it may be colleague facing, or it may be patient facing. So medical ethics or a bit of professionalism. For the medical ethics one, those are the things that would bother on like patient autonomy. So like the rights for patients to be able to make decisions for themselves, non-maleficence as in doing no harm, beneficence as in working in the best interest of the patient, and then justice, that is like treating everybody equally and fairly. In under medical ethics, there's some other things that will like other like sub pillars or sub ethics or something that come up quite often when you have to deal with ethical scenarios. So things like being able to assess capacity. So if they asked you, okay, if you've answered the question and you say, I want to check this patient's capacity, it's very likely that they're going to ask you a capacity related question. And for things like that, you have to know like all the 4 pillars of checking capacity, because you have to sort of rule them out, just so that you can say the buzzwords and then they can give you your full point. So capacity is something that you need to be very familiar with. The duty of candor is another one, because there are pillars under duty of candor as well that you have to be able to you have to be able to define and explain how you would use it. Because if you get a question that relates to duty of candor, then you have to sort of explain that. Another thing that comes up quite commonly is confidentiality. So they usually ask questions about confidentiality if it's reflecting in the scenario they give to you. And then they might ask you things like, in what instances are you allowed to break patient confidentiality? Why is confidentiality important? And all these things are things that you can find in interview books. And then when it comes to the more colleague-facing ones, I think a lot of the guidelines or a lot of the guidance that you can find on how to deal with colleague-facing issues are in the good GMC's Good Medical Practice. You have to. I don't think you have to read the whole book, but you have to know. You have to be very well versed with things. Like you have to be able to say, okay, I'm relating this to GMC's Good Medical Practice. A lot of the things there, that's like the guidance for the way we interact with our patients and our colleagues. So you have to refer to that a lot if you get that kind of question. So I'll just go quickly to the I Spied general approach. So it's spelled ISPIED. So the first I stands for issues raised. So if they ask you a question, like going back to that example of you have a patient that is agitating for self-discharge and they've asked you, how would you handle this scenario? You usually start by saying, okay, so the issues that are highlighted in this particular scenario have to do with issues that have to do with patient autonomy or patient this or non-maleficence or beneficence, or if you're dealing with your colleagues, you'll be like, okay, these issues border on patient safety and they also border on professionalism, things like that. So you always have to give a preamble of these are the issues that I'm going to discuss in this in the course of answering your question. These are the issues that I have found. Obviously, we're not robots. If you remember something else, like, so let's say you said it's patient autonomy, and then in the middle you realize that, okay, we're now going into non-maleficence. I think you can still say it and still get your marks, but anything you can think of is good to just throw it out. But I mean, obviously, don't say random things if it doesn't make sense. So that's the first thing about issues. The second thing will be seeking information. So if you get a scenario where someone says, oh, your colleague has been coming in late for work, how do you handle the situation? You don't want to be the person that, okay, no, I'm all for professionalism, so I'm not going to ask any questions. I'm just going to go straight to the rota team or go straight to the consultant. You have to ask questions about what is going on to your patients, to familiarize yourself with what kind of situation that you're in. Even when, like, sometimes they might say, okay, you're a doctor on a night shift, and it kind of goes back to saying what Dr. Zika said about you have to know where you are. If they're calling you about a patient, if you're on a night shift and they're calling you about a patient, you may not know this patient as well because you may not have worked on that ward before. So you want to get information from the person that is calling you, from the patient themselves. You want to get more information from the patient's notes. So just talk about what kind of information you think you will need and where you get that information from. I do want to say that at this point, like, try not to go down a rabbit hole of saying, okay, if the patient tells me this, I'll now tell them that. If they say this, I'll say, I want to get information about certain things. Just make it concise. And that's the S. The next letter is P, and it stands for patient safety. So at every single point, regardless of the scenario, you have to be sure that your patient, I mean, obviously, if it relates to patient safety, but a lot of the scenarios do relate to patient safety. You have to think about how patients may come to harm because of something that has happened in the scenario that they've spoken to you about. So you're okay. You can start by saying, after seeking information, I would be my priority is this patient safety. I want to be sure that this patient is this. Maybe that they're not still having, if they have any red flag symptoms, that mean the procedure we're planning for yesterday, we have to do it now. Or patient safety in the fact that this patient wants to go home, but I know that if they go home the way they are now, they're likely to come to harm or to deteriorate further. So patient safety is something you always have to talk about. Then you now go to your initial measures. So initial measures that's what the second I stands for. You talk about the things that you would like to do in that situation. So if a patient wants to go home against medical discharge, what can you do to prevent them from making that decision, not like in a way to coerce them, or what are the steps that you will take? So I would like to speak to the patient. I want to know why exactly they want to go home. I want to know what they understand about what is going on. These are the places where you start to talk about things like capacity. So you can just mention, I would like to assess their capacity. I would like to I would like to do this. Whatever you need to do in that situation, those will be your initial measures. And then the next letter is E. It stands for escalate. So because we're applying to be IMT ones, there aren't many situations where you can deal with a situation and close the book and be like, yes, I've done everything I can do. I don't need to involve anybody. You usually have to tell somebody about it. So even if you can say, okay, if this patient wants to go home and I've spoken to them, they agree to stay, all well and good. I think it's still sensible to tell somebody just in case they kick off again, or just find a way to just, okay, I'm going to still let my seniors know about this situation. I'll put it in the notes so that the morning team can know. Or if this patient refuses to stay, which is what you're more likely to get in an exam situation, you can talk about how, I've tried my best in my capacity as an IMT person, but I would like to escalate to my seniors because they may have more experience and they may have, better ways of explaining some things I haven't been able to explain properly. But, speaking to your seniors about it is always important. And then the last letter is D. So it stands for document, but there are a couple of other things you can do in that. It can be documenting, it can be reflecting, or it can be supporting. It depends on what the situation requires. So again, back to this patient that wants to self-discharge. If after everything this patient refuses to go, even if they don't leave hospital, you have to, we, as safe doctors, we always have to document the conversations we've had with our patients. So I would like to document this. If it's a thing where maybe someone has made a mistake, for example, somebody prescribe the wrong doses of drugs, you document in the patient's notes, yes, but you also want to say things like, I'm going to go in my own personal time and reflect on this incident in my portfolio, reflect on the things that I can possibly do as a doctor to make sure I don't make such mistakes, etc. And there are supports. If you get a scenario where maybe one of your colleagues came into work drunk, or one of your colleagues tells you that they've been depressed or they're going through something, after everything you have done, after going through the whole ISPIDE, to show that there's a bit of humanity in you as well, you also talk about how, I'd like to support this my colleague, or signpost them to resources that can be helpful for them. Like I want to talk to them about going to occupational health, or I want to make sure that they get home safely, or whatever support you think you can sensibly offer to your colleague. I think that's the whole approach. I have some examples here, but I think we'll do that in the Q&A session, so that we can have like a good example of how to really, really follow the ISPIDE approach. I hope it's been clear and helpful. But if there's any questions, I'm happy to answer them at the end. Thank you. That's it for me.
Thank you so much, Dr. Chemele, for that session. And it's very important if you underscore, really take on board everything they've told you, all the tips, because this call, Dr. Zika had 80/80, Dr. Chemele had 80/80, and ranked second nationally. So these are really, really good strategies. And welcome once again to everyone. If you've just joined during the session, this is the free IMT interview preparatory webinar by the ACE Academy. And now
let's hope that somebody on the call, or everybody on the call, will rank 80/80 and be back next year to do Dr. Zika's session and Dr. Chemele's session.
So that they'll be confused that how do we rank these people? So yeah. We're going to go to Dr. Balogun's next session, practical tips for preparing, because I think someone asked in the comment section saying the top ranking candidate, were they working in the NHS at that time? And the answer is yes. So Dr. Balogun will give some practical tips to help with your preparation while you're working as well at the same time. So yeah, Dr. Balogun. You're on mute. Thank you.
Okay, hello everyone. With regards practical preparation while you're working, or even for those people who are not working as well, you need to have like a set time with other people, maybe at most 4 people in a group. 2 people is ideal, but at most 4 people in a group. You need to have like a time, let's say like 8 p.m. every day, by the time when your shift ends, and then you can aim to meet for 30 minutes. Every day when you come, someone talks about their 2 minutes, and then the remaining people criticize them. And it's not just about what they say, but how they say it. Are they audible enough? Are they too rushed? Can people hear what they're saying, and all of those things? So it's something that you need to try to do every single day. And I feel like you can do it even while working in the NHS, except maybe on days when you do night shifts, because you may be really, really be tired and you may not be able to meet up with other people. But I think it's something that you can plan to do every day. Also, the things that they've said a whole lot of other things, but it's quite important for you to read your own application. And if you've applied, you've done it a long time ago, but try and read maybe 2 or 3 days. You can even read it tomorrow or today before the interview session. There are a couple of things you must have written there, you've forgotten, and there are things that they can pick you up on and say, oh, you mentioned about this QIP, tell me about it. So you should be able to say what role you played in the QIP and what was achieved with that. So it's good to read your own application before the day. It's also quite important for you to read through the IMT curriculum and ask yourself questions like, tell me about the IMT curriculum, or tell me about clinical governance in the NHS, or tell me about what you've done, blah, blah, blah. So it's quite important. And you can just go on Google and search for IMT curriculum, and then you would see the things that are expected to know. You don't really have to know it in depth, but just have an idea of what it is. It's a structured program that runs over 3 years. During this period of time, you're expected to do case-based discussions. You're expected to present accurately on well patients. You're expected to do a lot of clinical courses. Yeah, and also expected to finish your MRCP exams within that period so you can apply for higher specialty. Just something as brief as that, but it's good for you to kind of read about it as well. Very important. The other thing is timing. It's almost the most important thing about this preparation, especially that whole 2 minutes. So you need to actually time yourself when you're presenting and make sure that you stick to time. Next thing that you need to do is that I know Dr. Zika has mentioned this, so I'm just reiterating. The other things that have been removed from giving you points, things like leadership. No one gives points for leadership. I don't think you get points for courses that you've done. You don't get points for academic excellence. Let's say you had distinctions in school or you're like top 10%. This is the time to mention it. Even though you don't get points when you're applying, but mention it during this whole 2 minutes. You can find a way to factor it in that. It makes a lot of sense. Other practical aids to help out, it's like these mocks and webinars that has been organized by this academy. It's very important. You can book for some of the mocks, try and book it. You have people that will give you first-hand tailored feedback sessions as to what you did well, what you didn't do, and they're always available to like discuss with you. I'm sure you must have seen how interactive it is on the WhatsApp group. There's always someone willing to answer questions and all of that at all times of the day. So that's quite important. Other things that you could use is Medibody. So I use Medibody during my time as well, and it was really helpful. So that's something that you could have in a group and keep asking those questions back and forth. The medical interview group interview book has been sent on the WhatsApp group, so that's quite important. Something else to note too is when they ask you the clinical questions, don't just stick with the clinical part of it, A to E and all of that. Also remember there are other non-clinical parts, I put them in quotes, things like resuscitation, things like informing family if you've taken consent, things like follow-up, things like clean of care for that patient. I think for ward-based clean of care, do they need to be managed in ICU? Do they need to be managed in HGU? And things like your escalation plan as well. It's also very important that you mention, like, do you have to speak with your senior? Some people here may have been working maybe in registrar roles or working in roles that are more senior than SHOs. But when you're going for this interview, they want to see you as an IMT1 doctor. So there are times even when you're super confident about things, try and say you check in with your senior or you update the registrar or you check with the consultant. Don't say that you do some of all of these things by yourself, even though you have the competence to do it. Don't appear overly confident and don't appear like someone who doesn't know when to escalate things to the senior. There's going to be a handover session as well. So like the SBA approach is quite important. You need to practice that as well. How would you hand over a case? So that's part of the things that you need to practice. So like situation, background, assessment, and recommendation. Recommendation is as important as the other things. So you need to also say, this is what you recommend and all of that. I can see somebody asked a question on the group saying, I haven't done MRCP, is this bad? So that's not bad at all. If you have done it, you can mention it. If you haven't done it, it's not bad because that's not a requirement. But if you have done it, it's part of the things you just show commitment. But no one is going to mark you down because you haven't done MRCP. I'm just rushing a bit so that we can meet up with time. The next thing is about exam day nerves. So I would say if you're within the UK or you're in a place where you have good network, that's good enough. If you do not have good network, I would say it's very good for you to sort all of those things out. It may not be best to use your phone for this interview. If somebody gives you a phone call, it's going to distort things.
Do not use your phone. It is a never event.
Yeah, so don't use your phone. Somebody just calls you, if they spoil the whole interview, and all of these things is time because they have to go to another candidate. So yeah, don't use your phone. Make sure you get a laptop. Network is functioning. Make sure you check the time. There are lots of people from all over the world joining into this webinar, and I'm sure they're going to join all over the world for this interview. So look at the time difference. If you're somewhere else and they said UK time, 12 o'clock, make sure you work out what that time is in the UK. Don't go 1 hour early or 1 hour late. Make sure you have a means of identification as well. It's good to have your passports. If you have like passport or any national identity card, quite important because you're meant to show them there. Don't forget, make sure you have it done. Make sure you're in a place where there are no distractions. No one is coming to call your name or check up on you throughout the whole period. Because if there's anything that destabilizes you, it's going to make you feel bad. So just try your best that all the things you can control, make sure you can control that as well. The next thing is you're going to have 2 examiners that are going to mark you, and it's going to be independent. They're not going to say, what did you give him there? So let me give him the same mark or give him. So just know that there's probably not going to be any form of bias. They're going to give you individual different marks, and they're going to take the average, and you're going to have different sessions. So if you think you didn't do well in one session, Don't let it roll over to the next one and start shivering. I didn't do well in talking about myself, so the clinical one is not going to be good. Just keep fighting from beginning to the end and know that there's no form of bias. You're having two different examiners. The next thing is, the next thing is a lot of people say things like, so this is part of the exam day nerves. A lot of people say things like, oh, I got London Deanery. Oh, I'm really scared. Someone says, oh, I got Wales. Are they happy? I got Wales. Like, it's not as tough as London. Or somebody gets Scotland, like, I can't hear Scotland accents. So don't let all of these things be a problem for you. It's a standard all through the whole IMT. They're going to have standard number of questions. They're not going to have mean examiners. Even though, if, for instance, they have a mean examiner, they're going to have two examiners to make sure that there is no bias, and they're going to get an average. So don't start feeling bad, oh, I got London. They're going to know too much. They're going to try to bring me down. No, it's going to be the same stuff.
Can I just say something here, Dr. Balogun? I'm very sorry to interrupt you, because I've just responded to this particular misconception a lot, and I think it's important we sort of hammer the point in. If you've attended this webinar, there's no need for you to go out there and say again. You need to be the one correcting people. It's a big misconception about the deaneries. The deaneries have nothing to do with the interview. It's only so for the sole purpose of allocating facilitators, panelists. For example, the people in London cannot do the interview alone, or else patient care will suffer. So they allocate it to them based on days, and then some people will come today and the people in Wales will come next week. That kind of thing to stagger the effect on their clinical duties. So it has nothing, absolutely nothing to do with your interview, and your interviewers are there to support you to pass your interview, and you don't want to sort of get boggled down by that fact. Just keep practicing. Don't worry about the deanery for now. When you finish your interview, that it then gets a bit more, so when you get your scores, it then gets a bit more exciting, where you are now picking where you want to go and ranking things. Is that okay?
Yeah, thank you for having that. Yeah. The next thing is mocks. Try and do as much mocks as possible. If you can do enough mocks from this academy, that's really good. If you have a small group, you guys can still organize mocks for yourself and just time everything from beginning to the end. So the mocks are really important. It gets you into the exam scenario, and on the main exam day, you're just coasting, and it just comes as like a second nature. I don't know if this is important for everyone, but it was important for me. With respect to dressing, I'm not saying dressing gives any mark, but I had a tie, I had a white shirt, I put on a jacket. I just looked very formal. I just looked like I wanted to get this done. It doesn't mean if you wear a t-shirt that won't penalize you, but it just works for me. So if you can get into the whole mood, like just making everyone know, like, I'm really serious, I've come for this, I'm not leaving until I get this, I think that's good. I left it for the end because, yeah, it may not matter for people. I think Dr. Dosu want to say something here.
Hi, good evening, everyone. Yeah, thank you. I think that's a very good point in terms of dressing. You have to be very careful. I think there are the people who have told me that the examiners actually told them to stand up and walk behind. So imagine you're wearing a suit and then you're wearing boxer shorts underneath. I mean, that's terrible. So please dress properly. Yeah.
Okay. Yeah. So that's fine. So it's even important now. So I think everyone should dress properly, like you're going for an official interview. Yeah. And then lastly, just remember, if you've been working in a senior role that's higher than the IMT1, let's say you've had a lot of experience, remember that you should escalate when appropriate. Please don't try to say things like you are going to trombolize the patient on your own. Try and remember that you should escalate to your registrar or inform the consultant. Don't feel super confident. Good luck to everyone. Let's try to speak up during the interviews, make sure people can hear you. Yeah, and I'm rooting for you. I hope that it goes well for all of us here.
Thank you so much, Dr. Balogun, for that session. Very, very detailed, and you've highlighted the major points. Thank you so much. Welcome once again. If you've just joined halfway, welcome to the free preparatory IMT interview webinar organized by the ACE Academy. I'm Dr. Leah, one of the facilitators. I will just go straight to my session now, which will be about talking about what the interviewers what they want. And the reason is because over the past 3-4 years, I've been been involved in sort of organizing mock interviews for IMT trainees, and I've also been on the IMT National Recruitment Interview panel. So I've actually interviewed candidates on several of the days. So it's about, from interviewers' point of view, what I think is really useful for candidates. Now, they want to look at it that, are you safe? Safety is very important. And as I think Dr. Balogun has mentioned it. So some of you don't forget that this is the interview for IMT1. So possibly maybe you're already working at a registrar role. Don't confuse that, so that when they're asking you question, you're thinking, oh, I shouldn't escalate because I'm a reg. I can handle this. This is the interview. Make sure your mindset is that what would they expect from IMT1? So early recognition of risks, clear escalation to your seniors. Is it early? When do you need to escalate? They're looking out for that. And your decision making needs to be patient-centered, like what will be in the best interest of this patient. What is patient safety issues? You need to be able to highlight that. Also, they're looking for structure. Now, your answers needs to be logical, not generic answers. Because I've sort of, during the process of coaching some people, you just read or you're just answering question and it sounds really scripted. It sounds generic. What will make you stand out from the next candidate? That is what you want. So we want very logical responses. Very important. You need to prioritize clearly, like, what do you have to do? Do you need to go through A to E first, or do you need to address any red flag issues in the clinical scenario? Do you need to address that first before going? Efficient use of time, very, very important. Now, that is why you need to have a logical, structured approach to answering your question, because you don't want to be going down and you've not answered the question and they stop you halfway because they don't understand or they can't really make sense of your answer, and then you lose marks. And then, of course, they now have to ask you some questions which are compulsory so they can score you, but then you run out of time. So efficient use of time, and that only comes with practice, because if you don't practice, you would not know, oh, I'm running out of time. You would not know that I'm talking too much or using so many words without actually answering the question. It can really get confusing. So interviewers are really looking for that. Now, insights. Always remember, they're trying to look out for, are you able to reflect and learn from, certain experiences, or when they ask you a question, have you incorporated how you've reflected and learned from that experience? Is very important. Understanding your limits, knowing that, oh, okay, this patient is so unwell, this patient seems to be septic, no ceiling of care in place. Oh, I need to escalate to my reg early enough before I even start A to E to give the reg heads up or say, oh, could you join me? Not like you will finish the whole A to E and then you think, what next? And they keep asking you, what next, before you remember saying, I'm supposed to escalate. Interviewers are also looking for professionalism, and maturity in terms of how you answer. Now, how high scoring candidates, how they think differently, the high scorers would actually have a structured approach to their answer. Very important. They will state their priorities explicitly. Now, the first one that says pause briefly before answering, I'm not saying that you're pausing before answering. So trying to say, oh, thank you for that question, then you answer, is different from someone that just say, oh, the question you've asked me is this, and there's no structure to what you're answering. You are able to actually have a structure. And then, even if you pause before answering, you're not like pausing every minute or every 2 minutes or letting them signpost you. They are also able to verbalize risk assessment. You're verbalizing, because the interviewers cannot know what you're thinking about. You have to verbalize your answers within that time frame. Is very important. If you don't verbalize it, there's no way you will get scores. You have 2 different interviewers, and each one of them will be asking the question per time. They will be scoring you independently, and most times you would see most of the interviewers score will match, because like there's a template that interviewers you have to follow and say, okay, what are we looking out for to give maybe this candidate 5 or 4? So you should be able to verbalize. You need to justify your actions. Now, if they ask you, for instance, a clinical scenario, you're just doing your A to E. What will make you stand out from an outstanding candidate is that, being able to incorporate your differentials and what you expect to find into your A to E. You're not waiting, okay, A, I'm just going to check the airway. Okay, they've given you a patient shortness of breath, hypoxic. Okay, A, I'm checking the airway. B, okay, I'm checking the respiratory rate, I'm checking the SAT, I'm auscultating the chest. See, that is not an answer. What will make you stand out is, you're a patient with shortness of breath, hypoxia. I'm already thinking of this differential. Is this COPD? Is it PE? Now, on B, I'm checking the respiratory rate. If it's increased, I'm also listening for checking the SAT. If the patient is hypoxic, I will be starting patient on oxygen. I will auscultate the chest. Because if there's wheeze, I'm thinking, is there COPD? I want to start the patient on NEP. So you need to incorporate your differentials and you're diagnosing to your A to E, not just read it, because everyone else will go through A to E, but what will make you stand out is being able to incorporate it, also justifying your action. You're not just listing them, you want to justify it. Also, you want to make sure, reflection and learning is really something that reoccurs, particularly with your station one question. How have you reflected and learned from that? Very important. And common red flags that you see on the interview panel is that failure to demonstrate escalation or teamwork, unsafe independence. You are just acting without escalation. They've given you a scenario or something. You are not able to identify, I'm supposed to escalate this to my reg. I'm supposed to escalate this to my senior. You just continue. And maybe they have to keep prompting you. That's a red flag. Overconfidence without justification. Maybe you've had, years of experience working at a senior level, or and before this IMT one, and then you carry that mindset into the interview. That can really, really, it won't go well, because it's going to come off as overconfidence. So even if you have numerous years of experience, you work as specialty registrar or senior level, and you're appearing in the interview, you need to make sure your mindset is tailored towards this is the interview for IMT1. Rigid memorized answers. I tell you, the interviewers, at least when I was on the panel, you can tell that this is a rigid answer and this is memorized, like scripted, generic. It doesn't flow naturally. And the reason for this is because if you just think that all of these things we are telling you, all the tips we've given you, reading Medibody, optimize, everything is good. But what makes the difference is if you don't practice, and practicing with the right people that will give you the right feedbacks. And that is what we do, like coaching, the one-on-one coaching, the mock interview, giving you the right feedback so that you're not just taking on board, just practicing on your own or just reading all of that. And on the interview day, you don't want your answers to come out rigid. Ignoring ethical or communication aspects. They give you a scenario, you don't know the main ethical principles, you don't know the ethical issues, you don't know how to incorporate ethical issues. They're saying talk to family, you're telling the relative or the patient, this is a normal efficiency issue, this is a benefit. That is medical jargons. How do you break it down while still, communicating? It's very important. Not being aware of time, you've not practiced your 2 minutes personal statement. You're saying so many things. You're not able to sell yourself or bring out your strong point, and the 2 minutes is up. That's a red flag. Rambling or unstructured answer. They've asked you a question. How will you manage this patient? And then you start and just keep going. And you've not really answered the question. You've used so many words and time is up. Or not directly answering the question. Try to avoid that. When they ask you a question, you need to answer directly. Answer the question directly. Making unsafe clinical assumptions. Whatever you've not been given in the vignettes, whatever you've not been given in the scenario, don't make it up. Don't make things up. Don't say, assuming they know. Don't make things up. It's very important you stick to what they've given you. Not being able to, prioritize, or lack of reflection or insights. They ask you, tell me about a mistake you've made, or tell me about a time you've done something exceptional or something like that, and your answer doesn't include reflection. That's not good. Now, what makes the difference between an appointable and outstanding candidate? An appointable candidate, we answer the question. You need three. A score of 3 over 5 in each of the panel to be appointable. But with the way things are, you want to aim for outstanding. That's a score of 5. An outstanding candidate, we answer the question with insights. An outstanding candidate will be safe, will be reflective and proactive. You're even preempting. They're giving you a scenario. You can, even before you start, you can say, the oxygen sat is low. You already say, based on this oxygen sat, I'm going to start this patient high flow oxygen. You're not waiting till you go to your A, your B. You leave the patient hypoxic and you keep examining the patient and you ignore that fact. But outstanding candidate would actually recognize that. You are using your framework naturally. they won't ask you when they ask you a question and then you say, oh, you say camp, you say the camp approach, okay, I'm going to be using camp, and you start. That is a rigid answer. But someone that is outstanding will incorporate that framework and say, oh, oh, I have so and so years of the clinical experience, or the context of this, or what I did was this. You won't start saying, okay, the C now is context, the A is action. No, it needs to flow naturally. You need to justify your escalation appropriately. Oh, I think this patient will need, ICU for inotropic support based on this, and this is very important. An outstanding candidate will show clear commitment and maturity. Is very, very important. And always remember, this is IMT interview. You need to link your answers to IMT readiness, to IMT curriculum, not in isolation. Oh, why do you think you're a suitable candidate for IMT? Why have you applied for IMT? It's not just, oh, I've applied for IMT. I love internal medicine. Okay, so what else? That is a generic answer that has not really communicated to an interviewer that this is why you've applied for IMT. Oh, I love IMT because, I just love medicine. I love procedure. Yeah. So how does that make you stand out? Oh, I think you should choose me. I'm a suitable candidate because, yeah, I have good communication skills. I work well. I do this. You're just rambling the answer. You need to show clear commitment, and your answers need to be specific. Those are the things I think from an interviewer point of view, and being on the interview panel, I think in terms of what you need to look out for, the red flags, that common panel red flags, and what will make you an outstanding candidate. We're still going to take the question and answer section, but just so that we don't. Yeah, I think we're now in the question and answer session.
Yes. Thank you very much, Dr. Leah. And I've been trying to answer some of the questions in the chat session as they come along. But I think at this point, we can actually allow a few people talk, just for them to so that they're not just sort of at the back of the screen and mute. We'd like to hear your voices. So if you have any question, just raise your hand. We're going to let 5 people ask questions. And I think the first person that has raised their hand is Adi Gray.
Yeah, Dr. Agostina.
Yes, if you and we like to see faces as well. I mean, if your situation permits that, that's fine. Interviewers love to see confident faces. So good, well done. What's your question?
First of all, I would like to say a very big thank you to you guys for that informative session. Thank you so much.
You're welcome.
My question is, because I'm very new to this process, I just got in for GP trainee, but I want to confirm my actual passion is in IM. So my question is, when I think one of I don't know how to even. So I got the information about when you're being asked to give your 2 minutes introduction, the camp approach. So for the academic aspect of things, I wanted to ask if one can incorporate outreach, some medical outreach. Is it something that is quite is worth saying in that aspect?
Okay. I'll answer this question and then the other panelists can chip in. Medical outreach sounds like something you did in your community. It sounds like something that if you served as a leader on that, then it sounds like something that comes in the leadership aspect. The academic aspect is academic things. Say you're doing a master's degree program, you should put it in the academic aspect. If you've done a PG SAT, is academic. If you've done and then if you've now published papers in maybe peer review journal, or you've published case reports, those are the kind of things that they want you to put in the academic aspects. I hope that answers your question.
Yes, it does. Thank you so much. Thank you.
You're welcome. You're most welcome. Dr. Joy, can you unmute yourself and speak? We'd like to see your faces as well.
Hello, hi everyone. Can you hear me?
Yeah. Yes, we can.
I have a question. So in practicing with some of my colleagues, we always have this issue whereby if a clinical question is asked and, for example, you're given a case of an unwell patient and you are told to assess this patient, should you just, kind of give the A to E, give your differentials, your investigations, management, all the way through to the end, or just do your A to E assessment and then stop and wait for them to prompt you to say more? What do you think?
I'll say my piece, and then Dr. Leah likes clinical station, so she'll say her piece. For the clinical station, what an examiner is wanting to see is that, first of all, you're able to manage emergencies and identify an unwell patient and adequately assess and manage them. But after identifying that, you need to take a history, because it's not enough for you to identify that this patient is unwell. So you need to now find out why are they unwell. And in our clinical practice, we normally take history. The consultant, on the other hand, wants to know that if I leave my patient in Dr. Joy's care, Dr. Joy is going to ask the relevant question, so relevant history. And if the examiner wants to stop you, they will chip in. They normally they have the body language, and that's another thing. You shouldn't be robotic. You should be looking at them and see that, okay, if they want to stop you, then you quickly sort of pause at some point, rather than just stop and wait for them to tell you, okay, take a history. Do you understand? You will be different from the candidate that says, oh, after I finish doing my ATE assessment and troubleshooting and addressing all things that I have highlighted, I'm going to move on to take a quick history. And because of my differentials, I'll be asking about this, and this. Yeah. So then when you finish, talk about your investigations again, like just continue, because if you're such a good candidate and you're already telling them what they want to hear, they will just be marking you, they'll be ticking it, because you know what the examiner wants, and you're already running through it. Now, obviously, maybe after you get to the investigation, you then say, I'll be guided by my investigation results, and pause. At that point in time, they can project investigation results to you. But if every minute you say 2 lines and then you stop, you say 2 lines and then you stop, you're stressing the examiner. And it's actually, and I'm going to use the word irritating, that you are expecting the examiner to do the work of the interview for you, because what they are there for is not they are there to help you pass, but they are there to score you. They are not there to run simulations for you. They are not there to keep, coming into your scenario. It's your interview, and you have 7 minutes to do the clinical scenario. I think 10 minutes thereabout. And every time you stop, you're losing valuable time. Know when to stop, but don't stop every 2 seconds. Dr. Leah.
So I'll just give my own opinion. Being on the interview panel, I've also done several mock interviews. So when they give you the clinical scenario, after the reading time, the question can come in that way. They can ask you your differential first, or they can ask you, what do you want to do? Or what is your next step? Now, depending on what they ask you, you're supposed to have a list of differentials. Now, if they don't give you vital signs, it's about first assessing the clinical scenario. Are there any red flags jumping at me? Maybe they've given the vital signs. Patient is hypoxic, patient is hypotensive. The first thing you expected to say, oh, based on this is what I'm thinking about, these differentials. And then what I would like to do would be this. Now, in a patient in which they've given you a scenario where patient is hypoxic and hypotensive, and then you say you want to take a history, that would not be logical. What you expected to say, oh, I can see from this vital sign, this patient is unstable. I would like to first do this. Maybe, oh, you want to start this patient on bolus of fluid. I would like to put this patient on oxygen, and then I'll do a quick A2E, because at that time, you can see this patient is unstable. That's not the time to take history. And in your A2E, you are then incorporating all what you want to do, including your differentials, including if you want to do bloods and what you find on examination. And after that, you can then say, once this patient is stabilized, then I'm going to take a history if the patient is able to tell me, or look at the medical notes, or take collateral history, escalators needed. Now, if they just give you the scenario and you're saying, okay, oh, these are my differentials, and then I would like to take a full detailed history to ask about, maybe they should give you shortness of breath, about onset, duration, character of shortness of breath. Then if they wanted to continue that route, they will leave you continue. But if they think you're running out of time and that is not the question that you need to answer to score you mark, they're going to stop you and say, okay, so how would you assess this patient? That means they want you to move to your A to E, and you need to move. And then, of course, by the time you move to your A to E, you need to do it structured wise, and you need to incorporate your differentials, because not just by saying, okay, I would check the airway, fine. The B, I'll check respiratory, SAT, listen to the chest. C, no, that doesn't really make sense. You need to incorporate your differentials and your findings. So don't be rigid. depending on what they ask you. And they might stop you midway and then say, so what are your differentials? Or they might stop you midway, depending on if they don't think there's anything in your A to E, or if it's the investigations they want to move on to and move to that. So don't stop and expect, don't wait and keep quiet and wait until they ask you. They will stop you if they need to stop you. You just need to go on with your approach, and they will stop you and maybe give you the investigation results. So when you get to your B, for instance, oh, I'm going to maybe ask for chest x-ray. Don't wait and expect them to give you chest x-ray. If that is not included in the marking scheme, they will not say anything. But if that is where they want to stop you, they will stop you and show you the chest x-ray. So go on with your structure. Number one, identify the red flags, escalate as needed, move to the patient. The patient needs to be maybe in resource or in observation area. I need to get my SNE involved because I can see this patient is unstable, then I will do this. But don't ignore the red flags and leave the patient to like see before you then in an hypotensive patient. So yeah. I hope that has answered your question. Much. Yeah.
Yes. Yeah, that has been wonderful. Okay. Thank you so much.
Dr.
Sinduja.
Hello, hi. Thank you. Thank you for the amazing presentation.
We like faces.
I'm trying to click on the video, yeah.
That's good. It's a beautiful face too.
Thank you. I had a couple of questions. For example, in an ethical scenario, I came across one where there's a Jehovah's Witness coming in for an elective angiogram, and I'm going to consent the patient. So the issues that might be raised are patient would disagree with blood transfusions and all that. But what if I'm not comfortable enough or confident enough in that scenario to get the consent from the patient? Because usually it would be the consultant involved. So do I go ahead and get all the details, or should I bring the consultant in the first instance? How do I go about in that scenario?
Okay.
Dr.
Dosu, Dr. Balogun.
Can I just say something and then someone else would wrap it up? Yeah. So for that, what you need to know in the ethical situation, you don't have to win all the time. They're not there for you to make sure that you get the consent, that the patient must agree to have the blood transfusion. Yeah. They just want to see the approach, how you tell them what's going to happen. They might need to get some blood at some point in time. These are the other alternatives, but maybe if they were to lose a lot of blood, blood will have been the best alternative. In the meantime, because you understand that the Jehovah's Witness, did they have any written document about this? Is this something they've previously made a decision about? Would they want you to contact like the Jehovah's Witness doctors or organizations? Sometimes they also give information on what they want to be done in situations like this, and just let them know the risks and benefits. And then at the end of the day, they must not agree to have blood transfusion and have the procedure done. You could have done everything right, and they still say, I've heard all this conversation, I don't want to have this blood transfusion. You cannot force them, but you still get full marks if you explain things to them, if you make sure that you understand what they are saying, and you make them have an informed consent, and you talk about the fact that if they are happy, you could involve the relevant Jehovah's Witness organization to get some more advice from them in what they do in things like this. Yeah. So don't worry if they don't accept after you said all of these things. Yeah. Yeah.
Okay.
That's not the path. Yeah, that's not the sequence.
Okay, yeah. And I had another question. For example, in an overdose patient, I'm making sure the patient is safe. I'm doing all that bits. When I'm trying to cover a little bit of the clinical aspect, if I'm thinking, if I want to stand out and I'm thinking, okay, this might be a serotonin syndrome as well. And then I want to start with some medications, but what if I kind of blabber inappropriate medications at that instance? Should I just stop? I'll consider this and then I'll escalate to the registrar, or should I give them the medications or anything of that sort that would make me stand out?
So someone else is still going to give some more answers. If you have this sort of situations where someone has taken overdose and you're not sure, or you know one of the agents, but you're not sure what the right medication to give, you can clearly say you check the guidelines. There's something that's used in the UK, it's called Talkspace. I don't know if that. So you can say you check Talkspace, follow the appropriate guidelines, discuss with the registrar, make sure you do all of that symptomatic care, and then take things off from there. If you know the right medication, mention it. But if you're not sure and you mention a different antidote that will make things worse, you won't get good marks for that. They'll probably mark you down. So everybody checks Talkspace in real life. Yeah.
Yes.
Even if you've done it so many times, it's still good to check to make sure. Yeah. If you're not so sure of that agent, you can see national guidelines or Talkspace, discuss your seniors.
Okay.
Sure.
I just need to chip in something here. Yeah. Can I just say you're interviewing for the job of an IMT one?
Yeah.
Yeah. You are likely expected to be an F2. Yeah. I don't think you should make things complicated for yourself. Okay. They're likely not going to give you serotonin syndrome.
Yeah.
You are not expected to manage those kind of things or diagnose those kind of things by yourself. Common things occur commonly, and it's not just a show-off exam in terms of I know the complicated stuff. It's about doing the minute things like ensuring they have paracetamol levels checked. Do you understand? Yeah. Ensuring that you involve the MDT, maybe the mental health team. Those are the things that gives you a 5. It's not you cooking up very complex scenarios and all of that. So don't go out of the sort of curriculum and complicate things for yourself and get bogged down reading gigantic theoretical concepts that you don't come across in everyday clinical practice. It is very likely. And I'm going to do this now just to show you. Dr. Zika, what was your clinical station? Just what was the diagnosis? PE, thank you. Dr. Balogun, what was your clinical station?
It was alcoholic liver disease.
Fantastic.
Yeah, I think that was it.
If you work on a medical take in the UK, you will see alcoholic liver disease almost every day. Dr. Desu, what was your clinical station?
Hyperkalemia management.
Thank you. Which an F1 or a medical student should be able to do. Now, Dr. Leah, what was your clinical station?
I think just colitis.
Good.
Colitis, yeah.
Mine, during my IMT, which was about 5 years ago, was, I think it was TB in a patient that later developed maybe pneumothorax. You understand? And it was, again, pneumothorax is something that a medical student has an idea about. So you don't complicate things for yourself and start reading highfalutin stuff that are not applicable to the interview. Even this angiogram case, I very suspect that it is a HSC interview scenario. Do you understand? So just try as much as possible and not complicate things for yourself. Yeah.
Okay. Thank you so much.
Someone just asked in line with what you said, any extra mark for verbalizing right medication and dose? There are certain medication they expect you to know the dose and how to give it. For instance, treatment of hyperkalemia. You're expected to know at least the dose of calcium gluconate or calcium chloride, insulin dextrose. At least you're expected to know that. Now, for antibiotics, if you're then not sure of the strength, just say, antibiotic as per Strauss guideline. But there's certain things at least they will expect you to know, the dose of,
For antibiotics, actually following the Strauss guidelines supersede you naming medication, because you can think that chest infection is amoxiclav and in your trust they are giving ceftriaxone. So you just need to follow the Strauss guidelines. It's better than naming and cramming doses. Yeah.
Dr. Nair, you're on mute.
Okay. Hello. Hi.
Hi.
So my question is similar to the previous question that one of my colleagues asked, that some of the scenarios that you guys mentioned, like colitis, they aren't mentioned in MediBuddy. So any resources that you could recommend that would cover majority of the scenarios that could be asked in IMT just for revision purposes?
Oxford Handbook of Clinical Medicine.
Okay, and just the emergency cases, or
just go through medical emergencies. Yeah.
Okay.
To be honest, I think we shouldn't worry too much about. I don't want to downplay the interview, but I think you guys stay relaxed. To be honest, I think you already have all it takes to answer most of the clinical scenarios. Don't go around, like Dr. Sharma said, don't go around reading too much of highfalutin stuff, because the expectation is. You are coming into an SHO sort of role, really, and it's how best can you troubleshoot stuff to ensure that you are safe. Now, it doesn't mean that you shouldn't have the knowledge to answer all the questions. By default, if you've been doing, acute medical takes, or you've been going for ward rounds, or you have been going for clinics or whatever. I mean, you would have the basic knowledge. Okay, so don't be too scared about what scenario, what if I get this and I don't know how to answer this. There are ways to get out the loopholes, but at the same time, you should be able to at least have a good grasp of what the scenario is about, what's this diagnosis, or what are the differential diagnoses here, and how can I manage this diagnosis. So they're not going to be asking you fine details of highfalutin stuff like, what's the Madrid score, or what's the, I don't know, whatever score it is, scoring systems, for stuff. But for simple things like, PE, UTIs and RTIs, you're expected to be able to, handle such cases and also still escalate to seniors regardless. So I'm not saying you should go there without having good grasp of your medical knowledge, but I think, if you're able to go through the medical emergencies guidelines and you're able to troubleshoot stuff as you are as an SHO, I think you'll be fine in the interview. I think what the difference between someone who gets a 4 and a 5 is you being able to escalate, and that's what this interview is about. How safe are you, and how quickly can you escalate, and can you recognize the patient is really unwell, and how do I flag up this patient to my seniors? Do you get what I mean? So it's good to prepare well. Definitely, obviously, have all the medical stuff. It gives you an edge if you're able to rattle out the highfalutin stuff, but be very careful, because there's a thin line between trying to prove that you know everything and trying to prove that, and trying to let them know that you recognize your limits of your practice. I'll give an example. Like in my own case, and I think I've said this story to people who have come to the personal coaching with me, in my own interview. My interview was 6 years ago now. I think we're first of IMT, so I think 6 years ago. And my case was simple, hyperkalemia management. But I think the way I sort of handled the case, and they started asking, a bit of highfalutin stuff, like, tell us all the ECG features of hyperkalemia. And they showed me an ECG with a sinusoidal pattern, we know that that's very severe hyperkalemia. They said, do you recognize this? So I probably got to the point where they felt, this guy probably knows. Okay, fine. And then in my management, I said everything. I said everything possible, in terms of correcting hyperkalemia. I said everything. I said renal team. I had said, consultants. I'll speak to the consultant. And they said, you haven't said something. And I was wondering, what haven't I said? Because I've said everything. I've escalated to everybody. And they're like, do you recognize that you are the SHO? Who are you supposed to escalate to first? And I was like, I'm really sorry, my registrar. And they said, okay, fine, you can go. So this is just an example to tell you that it's about recognizing the steps of escalation. So even if I knew everything, I was going to call ITU, critical care, blah, blah, blah. That's good. It's good knowledge to have. But do you recognize the next level of escalation that you need to, highlight first before you say everything? I think that's the difference between someone who gets a 4 and someone who gets a 5, if you see what I mean. I hope that clarifies a few things for you guys.
Yeah. Thank you.
Yeah.
So I'll just add, reading the Oxford Handbook, the medical emergency section, it's good, because I've had, they can ask you things as workup for hyponatremia, workup for a patient, steroid dependency, or possible Cushing syndrome. But they would have expected, because that's also a level at least of IMT1, MRCP1, 2, and all of that will be in the medical emergency section. So it's about, revising it, and having a structured approach.
Yeah. Should we take one more question and then move on to the next station? Does anybody have any other questions? Any other questions? Okay. Yeah, Dr. Leah, over to you.
So thank you so much, everyone, for being on the session so far. Dr. Big, we'll just do the practice ethical scenario, then we'll take your question, if that's all right. So we are actually going to do practice scenarios for application and suitability, which Dr. Balogun will do, and then ethical scenario, Dr. Chiemele will do that one. So we need a volunteer.
So I'll just try and mimic the whole interview session. Yeah, I'm going to time you as well.
Yeah.
Stop you. Yeah. Okay. So Dr. Mohammed. Yeah. Okay. Good morning, Dr. Mohammed. My name is Dr. Balogun. I'm one of the interview panel today, and I'm here with Dr. Sheldon, who's also here with me for the interview. I'll be asking you a couple of questions. Before we go ahead, can you just show me any means of identification, please? No, you don't have to show me. You have to show them on that. Yeah. Okay. Right. So can you tell me about your achievements so far that makes you suitable to get into internal medicine training? Well done. I must really commend you for taking up, for volunteering to talk about it here. And there are a couple of good things you did. You mentioned that you've been in the NHS for some time, understand the workings of the NHS, you understand the concept of clinical governance, even though you didn't give any example, which is good. But I feel like the other things you could have said to sell yourself more. And there's something you said which was not too good, because you're trying to sell yourself. You said that you know how to do something, but that does not make you better than other candidates. That's like trying to drag you back to compare yourself with other candidates. You're trying to go above them. So basically, I would say that it was a good approach. I'm just going to list some things that I expect you to find a way to talk about them. Things like education, maybe like how many years experience you've got, things like your career, saying things like you've been able to do your foundation competencies and sign them off, because these are things that are required to get into IMT. Things like skills, if you've been able to do some particular skills like, let's say, lumbar puncture, abdominal paracentesis, those sort of skills, if you have been able to do them. Chest tube, if you haven't done it, that's fine. But things like abdominal paracentesis, maybe lumbar puncture, that should be fine. Things like if you've done things like quality improvements, so you can say things like, as part of clinical governance, you've been involved in a couple of quality improvements and audits, and then give an example. You can say an example that comes to mind was the recent quality improvement I did on antibiotic rationalization, where I found out that we're not using the right antibiotics in the acute medicine department, and I was able to do an audit to make sure that blah, blah, just a quick example of what you've done. So I needed you to talk about things like audits or research. I also need to talk about relevant courses that you've done. If you're in the UK, I suspect you must have done things like ALS courses. So it's quite important to say you've done your ALS course by Resource UK, and that makes you ready enough to take up emergency cases or to be part of the emergency team or part of the resuscitation team in the hospital, because you are aware you're going to be carrying blips when you're on call. So those type of courses are important. For me, I also chipped in that I did a burnout course. It was just a 1 hour course, but they asked me about the course and I felt like it was good. I said I knew that internal medicine was going to be quite stressful, and I've prepared adequately for this by doing a burnout course to show me how to properly rest well. I've forgotten the word I put, how to properly, prepare well for the stressful condition, something like that. And they were really impressed and asked me, so this burnout course, what did you learn? And I was like, oh, they told me to take regular breaks, get tea breaks, and they were impressed. So it was not just about knowledge. So courses are important. You've done like ALS courses, clinical procedural skill courses, mention them, acute medicine courses that you've done, kind of good. If you've attended conferences, find a way to talk about it. If you've had a publication, mention. If you have leadership, done anything in leadership, try to put it. Also, it's quite good to talk about your values as well. So you could say that you've had a couple of good feedbacks from your colleague, and one of them that resonates with you is that you're someone who knows when to escalate, when they meet the limits of their knowledge. Or one of them that stood up for you is that most of your junior colleagues have mentioned they are quite supportive, and involved in teaching them. So mention a couple of things about your personal values, and then if you find a way to say why you want to do IMT, that's also good. You kind of like to be in an environment that is very analytical and fast-paced, and you think that you've got what it takes to be able to be part of the system, that sort of stuff. For exams here, you've done your MRCP1, which is good. You can mention that. So basically, you need to find a way to talk about a bit about your education, about the fact that you've signed off your foundation competencies, about the fact that you've got certain skills. You've done part of the things of clinical governance like quality improvements. You've attended relevant courses. As part of your continuous clinical learning, you've been involved in things like publications or research. An example that comes to your mind is blah, 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 just a very short one. A little bit about leadership, talk about values, look for something good about yourself. Your colleagues have said you're someone who is hardworking, punctual, but something that stood up for you is that they said you've been very supportive, that type of stuff. A little bit about what you want to do IMT, and then if you don't exam, so that's fine. Yeah, someone is saying all this in 2 minutes. The truth is, if you write it down,
exactly.
Yeah, it's possible to say it's possible to touch all of this in 2 minutes, and you can keep revising it and make sure everything gets within 2 minutes. But you didn't do so bad because it's like your first
Can I come in here?
Yeah, go ahead.
Okay. So when you come to the personalized coaching sessions, yeah, that's part of what we can help you do. It looks very ambiguous, it looks all over the place, but our job is to take your 2 minutes presentation and show you how to make it concise, finesse it, and deliver it at optimal speed any time of the day. And you at that point where you get 5/5. And we're going to try and run a demo for you now, in which we're going to do the 2 minutes presentation. One of the facilitators will be doing it. So let's start.
So is anyone volunteering? Should I ask?
I'll do it.
Okay, all right, okay. Welcome, Dr. Shion. Welcome to the IMT interview. My name is Dr. Balogun. I'm one of the interviewers. I'm here with Dr. Dosu. Do you have any means of identification, please?
Yes.
Right, okay, so we're going to the first part. Could you tell me about your achievements so far that make you suitable to get into internal medicine training?
Thank you so much for that question. Over the last 7 years, I've had been practicing in medicine. I've had 7 years of clinical experience working in acute medical specialties, including cardiology and acute medicine. And during the time, I worked as an SHO, and I've been able to manage acutely unwell patients. I have skills managing deteriorating patients as well. And I've also developed clinical knowledge and important procedural competences. These procedural competences have been signed up for doing lumbar puncture and ascitic drains, and I believe these skills are very important for IMT. As well as my clinical skills, I also have passion for medical education, as well as doing work in improving patient safety. I currently organize teaching for medical students and junior doctors, including simulation teachings, and I've had excellent feedback to show for this. I believe this is very relevant in internal medicine training. I've also done a training in teaching course with a certificate to improve my teaching methodology. I'm passionate about patient safety, and because of this, I have led 2 cycles of quality improvement project on developing the syncope pathway. This created an improvement in referral to cardiology clinic and the neurology clinic for patients presented with the first episode of syncope, and this was presented in our departmental meeting. It led to a poster presentation, which I presented at the Royal College of Physicians Med24 conference. I've served as a clinical leader in different aspects, and one of my roles. Hello. Sorry.
Hello, yeah, we can hear you.
Yeah, one of my roles was organizing the rota for the SHOs, and this helped me develop time management skills as well as just working as part of the team.
Right.
From multi-source feedback.
Yeah, thank you so much.
You
made mention that you've done a quality improvement. How many cycles was that?
Oh, this was 2 cycles of a plan, do, say, and act, study and act quality improvement project on developing the syncope pathway. This was an impactful project because it limited the time for patients to go to the specialty clinics to 2 weeks from about 2 months. And I did a presentation in the departmental meeting for this.
Right. Are there any plans to make sure that other doctors still comply with the quality improvements recommendations which you've made?
Yes. In order to further improve compliance, we did a teaching program, just taking them through the guidelines, which was based on the ESC guidelines. And then this was uploaded on the Trust Internet so that they can have access to it anytime when they are working either on the take or in ambulatory care.
Right. So why did you choose internal medicine training?
Internal medicine training is one in which I've been always passionate for it, even since as a medical student. While a medical student, I particularly enjoyed the medical rotations. And over the years, I've worked hard towards improving my clinical skills, developing my passion for research, and also just improving my teaching skills, because I know all of these are relevant to a career in internal medicine. I've attended different courses, especially one of which was the Royal College of Physicians Med 24 conference, which during the time there was a lot of presentations. The one which I particularly fancied was the teaching on cardiovascular health prevention. I believe that going into a career in internal medicine would lead me to higher specialty training.
Right. Are there any work-based assessments that you know that is being done by internal medicine trainees?
Yes. Okay. Thank you for your question. As internal medical trainees, we need to go through the curriculum requirement. There are special curriculum capabilities in practice, as well as clinical capabilities in practice, and these are very useful. And to do this, we have to use an e-portfolio to document our workplace-based assessment. This includes ACATs, in which I know we are expected to have 5 ACATs a year, 4 ACATs a year, each including 5 patients. Then we are also supposed to do DOPS, which is directly observed procedures, getting sign-off for procedures like lumbar puncture, ascitic drain, and cardioversion, to mention a few.
Right.
There are also case-based discussions that should be documented.
Right. Thank you. Thank you very much. Moving on to the next session.
Thank you.
So guys, well done. You can see this. She did that first 2 minutes. I don't know if you heard my timer, but she finished everything within 2 minutes. I was ticking all the things that were. You can't see my book. Okay. Well, I kind of kept ticking. She mentioned about education. Spoke about her career. Spoke about skills. Spoke about quality improvement. Spoke about courses. Spoke about conferences. She spoke about leadership roles. Yeah, I think she spoke about teaching. I think the only thing that she didn't mention because of lack of time was something about exams. If she's done any, it's not a criteria. If you've done any, it's a good thing to mention. Of course, she's finished all the exams, but I'm just imagining like an end. Yeah, and then the other thing is research. I didn't hear anything about research and values. Yeah, but if I'd asked her, I'm sure she had answers ready for that. So that's like the whole 2 minute stuff. You can see the way she just
okay.
Yeah.
So can I just butt in there? That was not my portfolio. It was just a rehearsal. What I wanted to highlight there is that I didn't mention research. Yeah. But if you see when he asked me the subsequent question, I did not focus on clinical. I then said something about research. Do you understand? So rather than worry about, I didn't say research, and then not like become jittery in the exam, look for another opportunity to show that aspect of your portfolio. Do you understand? So you will not be able to say everything in 2 minutes. You will say the most important thing. There's something called your ultimate selling point, your unique selling point, one in which if you don't say in that interview, you've shortchanged yourself. What makes A better than B? What makes Dr. Leah better than me? What makes me better than Dr. Dosu? What makes Dr. Dosu better than maybe Dr. Balogun? If I leave my interview without saying what makes me better than every other person, I have not done well in that interview. So that's what you must say in your interview. After you say your unique selling point, you can then go through the motions of everything. And again, we use the CAMP structure, but if your unique selling point is teaching and your research is a film series research, you lead with your teaching rather than your research. After you say your clinical skill, you say your teaching. Now, again, when you come for the personalized coaching session, we would be able to identify your unique selling points. We will be able to arrange it for you. You would have a workshop on your 2 minutes presentation alone and until it is done. And by the time you hear, like, there is a stark difference between our candidates when they start and when they finish. It's like a difference. So we'll see you then. Over to you, Dr. Leah.
Yeah, thank you so much, Dr. Shion, for that, demo, and also Dr. Balogun. So, I mean, yeah, it's about really coming on board and really because we make sure you fine tune everything. And we'll just do one more ethical scenario practice. So, Dr. Chiemele, are you still on the call? Dr. Chi.
Yes, I am. Sorry, I was
Okay.
muted.
Okay, so
Are you ready for the ethical scenario? Okay. So you're a medical SHO who has just completed a night shift. You have come down to handover. However, it's been 30 minutes and the doctor who is taking over from you still has not arrived at work. You have now been called by a nurse in resource requesting that you review an unwell patient. How do you handle this situation? Okay, so are you ready?
Emily, after your
Oh,
feedback, after you're telling her the things that she did right,
okay.
we can run a simulation. Yeah?
Okay, so you mean like both of us?
Maybe well, both of us or any other
okay.
person in the panelist that wants
Okay.
to go for
Okay,
it.
so yeah,
Yeah.
maybe I'll just give another kind.
Yeah,
Maybe you
yeah.
can
So,
run this with
yeah,
somebody
let me
else.
circulate it. Yeah, just
Okay.
read the scenario.
Okay, so let me read the scenario again. Okay, so
Okay. Thank you so much for this question. At the moment, the main issues at play will be patient safety and also professionalism. To start with, because I've just finished the night shift, it won't be safe for me to go and see a patient. What I'm going to do will be number one, to find out what's really happening. So I want to find out if anyone has the number of the SHO or if there's a WhatsApp group, I can sort of reach out to find out if the person is running late. I'll be joining shortly. If I'm not able to do that, then there will usually be a registrar on call for the day shift. I'm going to approach the registrar on call and say, this is the situation. The person to take over the bleep is not here, to see if I can hand over that bleep to the person, because it won't be safe for me after a night shift to see another patient and hand over to the reg if they can take the bleep. And the other thing will be to contact the rota coordinator and let them know, saying the day SHO to take over from me is not present, and ideally I'll have to hand over the bleep and there's a patient to be seen. And of course, because I'm concerned about patient safety, I'm going to let the registrar be aware of the situation. Possibly if there's another SHO that can go and see that patient, or possibly if the registrar can see that patient. If all of these measures fails, there will usually be a consultant on call who I can approach and let the consultant be aware of the situation, saying, the day SHO is not reachable, we're not able to find out what's happening, and there's an unwell patient to be seen. That will be how I'm going to approach that.
okay. Is it ever acceptable to just leave the hospital in a situation like this?
No, because living in that situation puts patient safety really at risk, and also particularly because we don't know what's happened to the SHO. So patient safety and also even looking after the colleagues. So it's very important to escalate in the right way, which would be to first find out if I can reach the SHO, if I can find out if this person is coming or not. If not, because sometimes there can be sickness and the rota coordinators might be aware, or the person is running late, or we don't know. And even in instances, if no one is able to reach the SHO, I think we have the duty to possibly try to reach, if there's a named next of kin on the record of the doctor, or sometimes we might have to even contact the police to say we're really concerned about this person, we don't know how to reach, just to make sure the person is safe. But ideally, we shouldn't leave the hospital. We need to escalate appropriately, find out if there's another person, inform the registrar, inform the consultant on call, so that patient safety is not compromised.
Okay. So cover is arranged for the shift, but another SHO tells you that this colleague has been late several times over the last few weeks. How do you proceed?
I mean, because obviously I'm being told that this person has been coming late, but I don't want to assume. I really want to fact find and find out this information. So ideally, what I want to do is to contact the colleague and find out, to say, this is what has been happening. Is it right, to find out the information? If it is right, now if that's been the case, to find out the circumstances, relating to that. Is this colleague struggling? Is he dealing with maybe coming to work? Is the house far? Or just to find out what has really been happening. And then I want to find out if there's any steps the colleague has taken. For instance, is the supervisor aware? Is the consultant on call aware? Do they need to adjust the timings, work timings? Has the colleague spoken to the rota coordinator and all of that? And I really want to highlight to the colleague, saying, particularly it will impact on patient safety. Coming late to work will mean that possibly some colleagues are staying longer than they should. Patients are not being seen as they should, and the colleague might be missing handover. So I really want to highlight, saying this needs to really be looked into escalating involving the consultant. Now, if this colleague is not still able to tell me, or I'm not able to find out any information, then I'm going to tell the colleague saying, because this is an issue that has to do with professionalism and also impacting on patient safety, then I might need to escalate that possibly to the colleague's supervisor to let them know this is the issue. But I want to signpost this colleague to the right steps to do, informing the supervisor, maybe seeking help, speaking with the rota coordinator if it needs timing adjustment, or sometimes there's even travel allowance if perhaps the colleague is living very far away and needs to move closer to the hospital. That would be what I would do.
Okay. And you've spoken to this colleague and they mentioned to you that they're depressed following a breakup in a relationship. Who would you suggest that they speak to?
To start with, I'm going to empathize with this colleague. And of course, I want you to start with to really let them know, saying, if this is impacting on their health and how they're looking after patients, number one, they will need to first speak with a supervisor. Number two, we also have the occupational health where, doctors or healthcare professionals can seek help from. There are also some mental health resources available for even healthcare professionals. So I'm going to advise this colleague, number one, speak with the supervisor, speak with occupational health. And this colleague can also speak with the GP if they need some time, off work, just so that they get into the right mind frame, and so that they can get, possibly if they need sick note or they need some time off, so that appropriate cover can be provided for them, and also they can have the necessary support. But it will be important for the colleague to let the supervisor know to also contact patient health and GP if needed.
Okay, that's 5 minutes, exactly 5 minutes up. Thank you.
Okay.
Yes, because I was timing it as well.
Oh, okay, I didn't know.
Yes. Oh, so it was exactly 5 minutes.
Okay. Yeah.
All right, so do I still need to, because I think your presentation has given like a good correction
Give me the answer. Okay.
yeah.
So just to the audience. So even though it was literally like how she read it, so it's about if you understand what are the ethical principles, what you need to do, who you need to involve, then it will really make a whole lot of difference, because that's what happens in the interview. They literally read the question to you and you have to answer. And you want to make sure that you have the flow. You want to make sure you do the right thing. You want to make sure you escalate. But this is all we cover, because obviously, even now, we've tried to really ram everything to 2 hours. But even with that, we already past 9, and to cover everything. But this is just the highlight we've given you. But to really cover every other thing, you're going to. It will be better. We run personalized coaching, one-on-one. We have the mock, so that you can really go to town, go all lengths. This interview is very, very important if you've gotten an invitation to interview, particularly as an IMG, because obviously for next year, we don't know what's going to happen with, the prioritization and all of that. So this time is the time to really give it your all. Ask questions on the group, maximize the resources, take on board the coaching session, the mock interviews. Dr. Chemele, Dr. Balu, all of us will be on the group. You can ask questions if you're not sure of anything. And I hope you've really found this session useful and beneficial to you. Any question, any last minute tips, Dr. Chi?
I think I've said most of the things I found very helpful. I think the 2-minute presentation, having your presentation memorized and being able to say comfortably is really important. Having a dedicated study partner, going through your question banks, Oxford Clinical Handbook. I think this interview was the time I actually did buy my own Oxford Clinical Handbook to read the emergencies at the back. And then for the ethical scenarios, I know there's a lot of things that we want to say, but there are a lot of questions that they have to ask us as well. So just being conscious of the time that you have so that you can say what you need to say, and then they can ask you the follow-up questions, because that's where your marks are, in the follow-up questions. So that's it for me.
Yeah, so thank you, Dr. Chi, for spending time and really giving top tips. She had full marks in interview, ranked second nationally. Thank you. Dr. Balogun, last words?
Good luck. We're waiting for you guys. Make use of as much resources as possible. Yeah.
No. Thank you so much, Dr. Balogun, for taking our time. Dr. Balogun is IMT3 and has really been helping with mock interviews, with coaching, and even answering on the group. So thank you so much. Dr. Dosu, last words?
Yeah. So, well, I'll say well done to everyone, and good you guys have attended this session today. I think it's a very good exposure to what's expected in the interview. And I'll say thank you to all the panelists. I think you guys have done an absolutely exceptional job tonight, impacting people. And we hope that you guys do join our WhatsApp group. I think we have lots to offer. And the whole idea is to get you on track, because you're all competing with several people. I mean, you're probably going to be competing with almost 3,000, 4,000 people for how many slots? 1,500 slots.
Yeah.
So you need to put your best foot forward and do everything you need to do over the next couple of weeks, 2-3 weeks, because interviews are happening from January, really. So this is the best time. You can see what the difference is in terms of fluency, and for people who are well rehearsed and people who are just getting started. There's a stark difference between both sides of the coin. So you need to be yourself and give yourself that advantage. So I think do join us. We hope we'll be happy to welcome you into our group. I think take mocks as well, because that would definitely help you polish your presentation. So well done, everyone.
Thank you, Dr. Dusi. Dr. Dusi is one of the facilitators and also coaches in the personalized coaching session. Is ST7 Acute Medicine, about to be consultant. Dr. Shield, last words.
Hello, everyone. I'll say congratulations on getting a slot for your IMT interview. To be honest, you've done the hard work. The hard work was you doing that research project. The hard work was you doing that quality improvement project, starting it and finish it. The hard work was you ensuring that you had leadership skills and doing all of those wonderful work. However, the race has just started, because everybody that got shortlisted at 22 and 23. So everybody has done these things. Now, what will matter is entirely your interview, and you have to take it as if your career depends on it. Yeah. Over the next few weeks, it's going to be intense practice on our end. We as a faculty are committed, 100% committed. I've watched these guys go above and beyond, bend over back. We are doing sessions at 11 p.m. We are, to ensure that you guys are up to date, ready for the interview. What we need you to do is go onto the WhatsApp group, ask your questions. We're there to answer you 24 hours a day. No, well, not 24 hours. We do sleep. Yeah. don't send message past 11 p.m. at night. However, in terms of the personal coaching sessions, again, we have limited slots, because it's 3 of us and a few people helping us. We cannot take 100 people. So we have limited slots, and actually we sold out today, and we're going to open up another 10 to 20 slots over the next few days. If you're interested, book onto it. We have mocks, useful mocks. Now, no matter how well you practice, if you sit down, you keep reading theoretical stuff, if you don't practice saying it, you will realize when you practice saying it, then you realize that, okay, I'm not sounding quite right. So you need to do practice sessions, and then you need to do mocks. The reason why I emphasize on mocks is because when you practice with your colleagues, you're a bit relaxed. You feel like, oh, this is normal. And then when you get into the exam, when the adrenaline is pumping, you're just a bit all over the place. So when you simulate the exam scenario, you have full mocks. And then during that time, you literally are faced with people that you don't know, registrars, some consultants, you're sweating. So then you test yourself. You make your mistakes in the interview and the mocks. And then when you get to your interview, you go ace it. We are counting on you. We are rooting for you. And we are hoping that the people who will get 80/80 in this interview are all in this room. And we are looking forward to having you as part of our panelists next year. More importantly, we are welcoming you to the medical profession. That's where the cool kids are.
Yeah.
So yeah, welcome. Yeah.
Yeah. So thank you everyone for joining today's session. I hope you really found it useful and really informative, even though we try to put so much in 2 hours. But I hope this is a great start for you about your practice, about what it feels like, about what you need to know, the top tips of how to stand out and excel well. Please scan the QR code, just give one word, feedback. And also kindly complete the feedback as well. I've shared it in the comment section. and also it's on the WhatsApp group about today's session, so we can improve and even subsequent ones. Please maximize this. Give this interview your all. It's very important. Like, you just give it your all. Very important. So we have resources to help. We are there to help you. The coaching session, the mocks are there. So please just utilize all the resources. Thank you to all the panelists, Dr. Chemele, Dr. Zika, Dr. Balogun, Dr. Dosu, Dr. Shim. Thank you so much for joining. And thank you, everyone. Wish you the very best, in your preparation. And we hope that, this time next year that, you're back. You're like, we're having so many people to say, yeah, we had this call, you had this call. And yeah, have a lovely evening. You can still reach out with your questions if you want as well.
Yeah, if you put your questions on the WhatsApp group, we'll try to attend to it. And I know Dr. Balogun is there. I don't know if Dr. Zika is there. All of us, we are on there, and we would be answering your questions over the next few days.
Yeah. Please complete the feedback form. It's very useful for the panelists as well, and also for ourselves to see, what we can improve upon.
Thanks, everyone. Bye.
Yeah. Bye.
Bye. We'll just ask everybody that is not a panelist to please leave the group. We just want to run a debrief. Thank you.
Okay, 25 remaining.
I think we can all try to remove them from the group because some people may have been listening passively.
Oh, yeah. Okay.